The first question I have for you, Dr. Uzzo, is what's new in your practice or institution this week given the rapidly evolving COVID-19 crisis?
Well, everybody's trying to manage this with incomplete information and a rapidly evolving set of data, a rapidly evolving supply chain, and we're no different. So over the course of the last 7 days, we've continued to tighten up screening efforts on the front end for patients coming into the institution. We've continued to tighten up, how we allocate visitors and how we communicate with patients and how we do our video and telehealth visits. We continue to reassess almost daily which patients with cancer meet criteria where the biology of the cancer, and the risks therein outweigh the biology and the exposure to corona risks. I think in Philadelphia at large, there's this notion that we're about to experience a peak, so we're trying to coordinate our efforts with other local healthcare systems and understand what state and local municipalities and governments are trying to do to have what's thought to be an oncoming surge of patients. So for the most part, we're managing those issues as well as PPE issues and supply chain issues that continue to sort of wreak havoc on the ability to deliver timely care.
Perfect. And then do you think you could expand a little bit on some of the measures that have been put into place at your institution to prevent the spread of the virus?
Well, I think that we're learning, as other people are, about best practices, about barrier protection and social distancing. Everybody's heard that those are the most vital aspects of preventing spread. So wearing masks, having everybody in the institution wear masks, having them wear N95 masks for the greatest risk of the procedures, for example, upper airway, head and neck, thoracic surgery, and perhaps minimally invasive procedures as well. Those N95 masks are being used, and for the care of patients, having had those procedures on the floors, those are the kind of PPE measures that we've been taking into account most aggressively in the last 48 hours.
Perfect. So what exactly do your testing and screening practices look like right now?
Well, here too, we've evolved our screening over the course of the last several days. Initially, we were asking physicians to use their best discretion in terms of how the cancer and the biologics and the kinetics of the cancer may put the patient at risk for what could potentially be collateral damage. That is to say that a delay, even if it's done with the best of intent, might affect that patient's overall outcome from a cancer perspective, and how to weigh that against the risk of the coronavirus and potential exposure and treatment during this pandemic. So that was far more discretionary in the past. We've really taken an organic or grassroots or bottom-up approach to this. We've allowed teams to try to tighten those guidelines, disease care teams to tighten those guidelines. Specifically in surgery, we've really asked each of our divisions to socialize much more stringent measures to see whether or not and how to compare and contrast the care of, say, an esophageal tumor to the compare of say, a thoracic or primary lung tumor. Are there alternatives? Are those alternatives to delay surgery and hospitalization equally viable? Do they put them at higher or lower risk? For example, one great example people have been talking about is breast cancer. There is certainly, an urgency to the management of many types of breast cancers, but, inflammatory breast cancer, for example, has a different sense of urgency than, say, DCIS. Is it possible, for example, to put people on temporary hormonal management? Does that change their outcome? Does that allow us to safely delay without potentially changing outcome? The same thing could be said for prostate cancer. adjudicating, prostate cancer risk for localized treatment, and whether or not hormonal therapies might be able to mitigate those risks pending the ability to treat the primary, have all been very difficult questions that we've been grappling with. About 2 weeks ago, we were leaving many of those decisions up to the individual physicians, and within the last week or so, we've really tried to take that to a higher level so that we're having almost mini tumor boards among our divisions where there's got to be far more consensus about these decisions because they're hard to make.
Yeah, and I know a lot of patients right now with cancer, excuse me, a lot of patients with cancer who are in the middle of their treatment, like you were mentioning, there's a lot of confusion on whether or not they should be seeking immediate care or if they should be delaying their treatments in their care. And I know in your article that while I was looking at it, there was a figure on guidance decisions about immediate care for the treatment during the COVID-19 crisis. So do you think you could just talk a little bit about that and expand upon that figure more?
Sure. So I think we, like other institutions that care for cancer all the time, have spent a great deal of energy going through the exercise of asking very hard questions about is it safe to delay initial treatment? That is to say, is it of low enough risk to delay more than 3 months? So that's been sort of our green category, yes, you may delay. Our yellow category is intermediate, that is to suggest that a delay of about 3 months should be acceptable to the best of our experience and the best of published evidence. That's our yellow category. And then there's a idealized or a high risk of progression from cancer where no delay is considered appropriate, and that would be our red category. So to the extent that we have been able to parse and sort of segment various tumor types, and as best as we can with the complexities of tumor conditions and competing risks and age and other mitigating circumstances, where you can't just put all patients with, say, high-risk prostate cancer into one of the red, yellow, green categories. How do we adjudicate for patient comorbidities and for the nuances of the extent of disease and the volume of disease and the other measures of biological risk? How do we do that? So we've gone through that exercise, and in this article in Annals of Internal Medicine, we've done our best to try to show people how we're doing it, and I think that's rather consistent with how other institutions have thought of it as well. And we've then segmented each of those into the surgical side and onto the sort of hem-onc side. That is to say, can we delay them surgically versus can we delay them with systemic therapy? And so basically this brought us to 6 conditions: red, yellow, green, each for surgery, each for systemic therapy, and we use this as sort of our high-level guidance.
Oh, excuse me, I was on mute. So is there any data that we have seen so far that could show if there are certain patients that are more at risk? And I've also been seeing that sometimes COVID-19 can present as gastrointestinal symptoms. Is that true? And then do you think you could speak to that a little bit?
Well, so there were a number of so COVID-19 patients can present with all sorts of symptoms, anywhere from asymptomatic to Florida ARDS, depending on the time course of the disease, the viral load. Now, I'm not an infectious disease specialist, but there's any number of ways and symptoms that may mimic or may sort of be telltales for COVID-19 infection. Some of the data that we've been looking at, there was a recent article in Science that looked at 9 patients and looked at viral loads in the respiratory secretions versus the blood versus the stool versus the urine, and they distinguished between RNA and replicating virus. That is to say that just because you find RNA in some body secretions doesn't mean that there's actually competent replicating virus in those areas. So at least in this particular paper, and it looked at, I think it was 9 patients that were known that had known COVID infections. The suggestion of the paper and the data, albeit limited, was that while you might find RNA in the stool, that active and replicating infectious virus in the stool in this small cohort wasn't that common. Nonetheless, there's been, from the surgical side and from the procedural side, there's been a lot of information and a lot of concern regarding whether aerosolized virus puts healthcare workers at risk. For example, a lot of data has been coming out from professional societies looking at the risks of minimally invasive surgery. Can virus be aerosolized during venting procedures that are common during minimally invasive surgeries? Can it be aerosolized during bronchoscopy, probably at a much higher degree than during colonoscopy, for example? So all of these things we're trying to integrate into the way we approach patients and sort of what we believe the risk-benefit ratio is in terms of treating the patient, investigating their disease, and or delaying the care that we believe they need.
And then I know we've been talking about how there are a lot of challenges with COVID-19 right now, but personally, what is the latest challenge that you've been experiencing with regard to the pandemic?
Well, one question that patients have is that they feel as if that their cancer may progress and be collateral damage, if you will, because of increasingly limited resources, the sort of lockdowns that are occurring and the isolations, the social distancing. So trying to manage patients' worries, fears, concerns that their cancer is worsening and that this situation is allowing that to occur by no fault of anybody's is a real challenge. It requires a far more robust communication with patients to assure them that to the best of our knowledge that's not happening. But unfortunately, it's based on incomplete data. It's really hard for us to know what the natural history of many of these diseases are when we simply haven't studied them. There's just an insufficient amount of data to suggest what happens when you watch metastatic cancer of any type, because it's just not that commonly done in otherwise well, healthy, and able individuals. Perhaps there are data, and there are, for watching cancers in patients that are otherwise highly comorbid or that have a limited life expectancy, and to understand what happens in advanced cancers in those patients is a little bit more well understood. But frankly, the natural history of untreated cancers of most types is not well understood. The tendency in this country and across the world, obviously, is when you see it, you treat it. Unless there are mitigating circumstances, we simply don't have anything other than, in some isolated cases, early, low-stage, low-grade, low-risk prostate cancer, perhaps small renal masses, perhaps some incidental lung lesions. There are some data like that, but for people who you think need treatment, there's not very much data to suggest or to guide you in having that discussion. And so your question as to what are the more concerning or difficult aspects of this, it's really trying to be there for the patient, to give them counsel, to give them comfort, to give them some sense that they're not being compromised without having data really to back you up and do so. So a lot of it is just based on gestalt and clinical judgment and clinical experience and anecdote.
And then speaking of a few more challenges with COVID-19, I know you kind of mentioned this before, and it's also kind of mentioned more towards the end of your article, but are you experiencing any supply shortages such as personal protective equipment? And what are your procedures for preserving your personal protective equipment? And I've also seen quite a bit of news now that there's a low amount of blood donors as well. So that's a huge issue as well.
So we've been very, very fortunate to have a very forward-thinking and really excellent people in our supply chain. For PPEs in particular, it's not that we haven't experienced some shortages like other places have, but we've been fortunate in regard to most PPE. The N95 masks seem to be sort of a flashpoint or a focal point. There has been some data out of Stanford suggesting various ways to treat and reuse those masks, something we would never have considered, about a month ago. Can you use steroid? Can you use heat? and how often you can do it, and what's the efficacy of the mask afterwards. So we've been using those guidelines for N95 masks, which has been one of the areas that we've had to focus our efforts. The second area that we've had to focus our efforts, frankly, are on swabs. This is really, something that I think everybody is experiencing. It seems that as more and more testing comes online, either done organically within your institution through certified CLIA labs or through third parties, one of the problems that most people are experiencing, us included, are test swabs and kits to do the test. The technology to do the test, the reagents to do the test, the primers to do the test, they seem to be fairly adequately supplied. But the swabs, and there are some nuances of it. You can't use cotton swabs, you can't use wooden swabs because it can affect apparently some of the test results. That's a concern with supply chain. Otherwise, we've been really debating internally about the sensitivity and the specificity and the negative predictive value of these tests. There is a known phenomenon that a negative test, depends, on a lot of factors, including pretest probability and, the obtaining a good sample. So a negative test may not truly be negative, and so how do you monitor and manage that if you want to give reassurance to the patient that they've tested negative and they can proceed with some degree of comfort with their care? How can you drive that conversation to the point where they understand some very basic, shortcomings of screening and testing?
And then I only have 2 questions left for you. Are there any ongoing research efforts that you're finding particularly exciting?
Well, I would sort of group those 2 things into both diagnostics and therapeutics, right? So for diagnostics, this concept of point-of-care testing really is a game changer for testing for the presence of the virus. And so we've all heard that Abbott Labs is now developing or has developed a point-of-care test with a short turnaround time. That really can change how we deliver cancer care. Again, as I alluded to a minute ago, a positive test is very sensitive. A negative test, unfortunately, isn't. So how do you manage that? So testing is the first area that I think is exciting, and the shorter we can make these turnarounds, the better. I mean, just 2 weeks ago, testing was routinely in most places taking 5 days or so. That's been shortened down to 48 hours, maybe 24 in many places. The ability to take it down to 3 or 4 hours would be and is really sort of a game changer, and sort of to tighten up the testing characteristics would really change things dramatically. So from a testing perspective, that's the first thing. The other thing is, of course, there's in the last 24 hours new guidance and even an FDA approval on serological testing to see if patients have been exposed and have antibodies. And I think that's really the next big wave in diagnostics, not just testing for active virus, but testing for prior exposure and infection. That really will be a game changer there too, because if you could tell us, if we could tell who's not only been exposed but is immune, if you will, despite the concepts of or the potential risks of reinfection, but at least somebody who's had the virus, whether they were symptomatic or not, when they've recovered and convalesced, and you can tell us that they've got antibodies against the virus, then suddenly you can take them out of your need for a higher tier for screening if they're coming to your institution for care. So that's on the diagnostic side. On the therapeutic side, right, everybody's talking about the potential for a vaccine. I think everybody would also concede that that's a fairly long way away. In the best case scenario, you're probably talking about a year, despite everybody's best efforts. Those are hard things to sort of test, to develop, to test, and to roll out. In terms of therapeutics, right? Who knows, right? Just like with cancer care, most of these new therapeutics will be tested in patients that are in most dire need of them. when all other options and supportive options have failed, and they'll work their way backwards. So whether these new antivirals, monoclonals, or old remedies like hydroxychloroquine will work, we'll probably find out, at least in anecdotal and case series, in the next week or two, I hope. But that will be tested in those that are most severely and profoundly affected, and then they'll start to back up the use of those things into patients in earlier stage disease.
And finally, my last question is, what do you feel is most needed to slow the spread of COVID-19?
Well, to slow the spread, right now what we have is social distancing and barriers, so it's education. Probably, for people to recognize, and I think that it's widely accepted that those are our best defenses against it right now. But I think for people to recognize that that is still, something that unfortunately we have to commit to. In terms of slowing the spread, I think you also get, if you work on it on the back end, as I was alluding to before, having, adequately addressed the risks of and the treatment of patients in the intensive care unit that have aggressive and unfortunately very morbid disease. If we could come up with a way to really mitigate some of the cytokine release, some of the immunity associated with an aggressive COVID infection, and mitigate the death rates, for people in the ICU, suddenly, if you're working on it from both ends, the sort of preventative end, and on the backside, sort of the end stage management of these patients, and you can start to lower the death rates, then suddenly things can start to open up a little bit better, and we'll begin to sort of regain some normalcy.
Perfect. Well, thank you so much for your time, Dr. Uzzo, and spreading your knowledge with us, and also hopefully giving people some peace of mind who do watch or read this interview. So thank you again. It was a pleasure speaking with you.
Thank you very much, and good luck to everybody.
Thank you. Have a good one.